Dear colleagues, welcome everybody to today's webinar of the WBMT on ABO mismatched bone marrow transplantation. It's a great pleasure for me to welcome you. My name is Jörg Halter. I'm a hematologist of the University Hospital in Basel, Switzerland, and part of the cellular therapy program team. Today we have three distinguished speakers I will introduce shortly. ABO mismatched bone marrow transplant has been an issue since the beginning of transplantation. We know so far that it does not impact the outcome regarding the overall survival or GVHD, but it clearly is a challenge for performing transplantation safely because there are additional issues that have to be considered, how to prepare the patient, and what about the transfusion policy, and maybe also graft manipulation. It's my great pleasure to introduce three distinguished speakers. First of all, Professor Georg Stu from San Giovanni Hospital in Bellinzona, Switzerland. He has a long-standing interest in ABO incompatible transplantation, has also worked a lot in this field, and he is now the head of the hematology of San Giovanni Hospital in southern Switzerland, and we still have a very strong collaboration. His team is part also of the allotransplant team of the University Hospital Basel. And his talk about recipients preparation in ABO major incompatible bone marrow transplantation will be followed by the talk on red cell depletion from ABO incompatible bone marrow grafts by Professor Nina Worel from Vienna. I think everybody in the field of WBMT knows her in various positions. She's the head of the donor outcome committee. She gave a lot of impact in the development of the factor chassis standards, and she's a specialist in transfusion medicine, apheresis, graft manipulation, and processing, and we are looking forward to a very interesting talk. And finally, there will be Professor Laura Infanti from University Hospital Basel. She's a transfusion medicine specialist and our partner when we perform ABO incompatible transplants, as well as in every other transplant setting. And she will talk about the transfusion policy in ABO incompatible bone marrow transplantation. We will collect the questions you have. You have a button on your screen for Q&A. Please use it to put your questions in it. And we will answer these questions during the panel discussion at the end. Or if there will be too numerous questions, we will also try to answer them during the next hour. And with that, it's my great pleasure to introduce Georg Stu from Bellinzona and invite him to give his talk.
Thank you very much, Jörg. I will now share my screen and hopefully everything works. Do you see it? So, welcome also from my side. It's a great pleasure to be here and to give this presentation on recipient preparation in ABO major incompatible bone marrow transplantation. I will give my talk in three major parts, which is I will give a brief introduction into ABO incompatible stem cell transplantation. Then I will talk about one of the major complications, which is the pure red cell aplasia. And the third part will then really be to dig into a bit more in detail in the different technologies in order to prepare the recipient prior to major ABO incompatible bone marrow transplantation. Now, we all know that in contrast to HLA, mismatching of ABO blood group system is not an impediment to hematopoietic stem cell transplantation, and therefore roughly 20 to 50% of all transplants are ABO incompatible. There are three ABO incompatibilities, and we looked at the percentages in a rather large study of the IBMTR a number of years ago, where we had over 3,000 bone marrow transplants, and you see that roughly 2/3 of the patients are ABO identical, then 14% were ABO minor, and 14% were ABO major mismatch, and a little bit less than 4% had a bidirectional ABO mismatch. Now, what does that mean? The minor ABO incompatibility is that you have, for instance, a donor as blood group 0 and the recipient blood group A, and that means that the donor has preformed antibodies to the recipient red blood cells, and as a consequence, if you don't do anything, then you have an immediate hemolysis of the recipient red blood cells by the Graft isoglutinins, and you can have a passenger lymphocyte syndrome 2 to 3 weeks after the transplantation. In the contrary, the major ABO incompatible situation is that the recipient has preformed antibodies to the donor red blood cells, here donor blood group A, recipient blood group 0, and the consequences are that you have an immediate hemolysis of erythrocytes in the graft, and you can have a delayed red blood cell engraftment, or you can have pure red cell aplasia. Now, the most important thing, as has already been mentioned by Jörg, it is feasible to do ABO incompatible transplantation. There is no differences in the overall survival. There is no difference in the transplant-related mortality and relapses. There are a number of studies who showed smaller differences, but if you go to the larger studies, then basically there is no difference. And with that, I would like to come to the major incompatible stem cell transplantation and pure red cell aplasia. This is a case of a patient where we had anti-donor isoglutinins prior to transplant, and at the time of transplantation, they went down to 0, and as a consequence, the reticulocytes of the boy emerged rather rapidly. But then in a second step, there was a re-emergence of the anti-donor isoglutinins, and as a consequence, the reticulocytes disappeared again, and they remained low until more than 200 days, when the titer of the anti-donor isoglutinins was less than 1 to 2, and that was the threshold where the erythropoiesis could engraft again. So this is a classical situation of a pure red cell aplasia, which you also always see in the right panel, where you have all the different cell lines except for red blood cell precursors. Now, why is that so? This is because the blood group ABO antigens, as a matter of fact, they are not only on mature red blood cells, but they are also in the precursors of the erythropoiesis, and you see here that it's up to the pro-erythroblasts that the blood group antigens are expressed, and therefore the circulating antibodies against the donor erythropoiesis can also attack the precursor, not only the mature cell. Now, the question that we had then is whether the preparation before major ABO incompatible transplantation could have an impact on the incidence of pure red cell aplasia. So we looked at basically two groups. Group 1 was a group where we did not do any recipient preparation, but there was the group that received removal of red blood cells from the bone marrow. And as a consequence, post-transplant, this group received transfusion of recipient-type red blood cells. The second group, however, was the group where we removed the anti-donor antibodies by different techniques prior to transplantation. The techniques were plasma exchange or in vivo adsorption by transfusion of ABO incompatible donor-type red blood cells. Those patients, as a consequence, received also after transplantation donor-type red blood cells when they required transfusions. Now, the indication to choose between one and the other technology was that basically if you had very high titers, then we tended to do more plasma exchange. So if you had a titer of more than 1 to 64, 228, usually we started with plasma exchange. If the titer was more than 1 to 16, then it was started with a transfusion of donor type ABO incompatible red blood cells. And in patients that had very high titers or where the titers did not go down sufficiently by plasma exchange, there was a combination of plasma exchange and incompatible red blood cell transfusion. Of course, during this period, every day, daily determination of isoglutinins were performed and also of the hemolysis parameters. Our goal was to continue with the transfusions and the plasma exchange until the titer was 1 to 1 or 1 to 2, which is a bit more stringent than other titers reported. Now, what are the results? Here you see the effect of the isoglutenin titer reduction. On the very left, you see the patients that didn't receive any manipulation. They had a median titer of 1 to 32. Then you see the ones that receive plasma exchange, and you see that there is a good reduction of the isoglutenin titers. You see that the ones that had in vivo absorption with incompatible red blood cell transfusion had a little bit less of isoglutinins before, and there was also, they went to a median of 1 to 1. And you see also that the ones that received the combinations had tendence of higher pre-transplant isoglutenin titers, and also afterwards it were a little bit higher. Now, the isoglutenin titer reduction had an impact on erythrocyte engraftment. Here you see on the left, in the left side panel, that there is a clear delay of the engraftment of red blood cells in patients that did not receive isoglutenin titer reduction. Now you can say this is due to these patients here who were patients who had pure red cell aplasia. But even if you take out those patients, you still see that there is a significant difference on the right panel between the ones that received isoglutenin titer reduction and the ones that did not receive any reduction. And also, the incidence of pure red cell aplasia was different into two groups. You see, we had a total of 12 out of 153 ABO major incompatible transplants who had pure red cell aplasia. And in the group with isoglutenin titer reduction, there was 3 out of 98 or 3%, in contrast to the ones that had no isoglutenin titer reduction. There was 9 out of 55 or 16% of the patients who developed a pure red cell aplasia. You see the engraftment curves, it started around day 200. And the median time until red blood cell engraftment was 225 days. It was self-limiting in all cases, so we did not do specific procedures, and all the patients engrafted sooner or later. But the transfusion dependence was clearly higher. You see that it was 36 concentrates in the ones with pure red cell aplasia versus 12, so almost 3 times the transfusion requirements between the two groups. And you see also that most of those patients who developed pure red cell aplasia were A into O, and there were the 3 patients on the right side who had isoglutenin titer reduction, but you also can see that they had quite high isoglutenin titers before starting the isoglutenin titer reduction. Now, coming to the preparation of the recipients before major ABO incompatible transplantation, there are 3 major strategies. One is the plasma exchange. The second one is immunoadsorption. The third one is intentional donor type transfusion or in vivo adsorption. It is clear, and it is very evident that there is no consensus in the literature with respect to what is the most efficient strategy. So there is no winner, and I think many centers have chosen a specific technology for themselves. It depends on the center's preference and also what they have as potential and for logistic reasons. Now, plasma exchange, it is also, some centers use it, some centers don't use it. You see here a questionnaire that was sent around Italian centers, and at that time, roughly 55% of the centers use plasma exchange in the based on the level of the immunohemagglutinin titers. But there was a huge difference in the starting titers, so between 1 to 8 and 1 2024. 41% of the centers never performed plasma exchange, and 2.9% always performed plasma exchange independent of the isoglutenin titer. It is a non-selective removal of plasma, so you have to replace it with albumin and fresh frozen plasma. It is quite efficient to reduce isoglutenin titers, and therefore we had it as the indication of the high isoglutenin titers. Now the timing is also not very clear. It's sometime during conditioning regimen. It depends also a bit on the conditioning regimen and when, from a logistic point of view, it is feasible for the center. From a pathophysiological point of view, I think it makes sense to make it as close to transplantation as possible. Now, the frequency of the session is also different. It usually is from 1 to 3 sessions, depending also from the titer kinetics. And the target titers were to stop were between 1 to 16 and 1 to 8. And as I've shown you before, we were a little bit more stringent. But it is logistically demanding, and also the volume shift within the patient can be a challenge. There are very few data. Most of the guidelines cite 2 papers that have been published by Buckner in 1708 and by Benzinger in 82. And if you go to this publication, indeed, there is not so much detail about the procedure. There was one more recent publication who showed their experience with plasma exchange, and that's what you see here. You have the column with the initial titers, and you see the variability, and then you see how many of the plasma exchanges they did. And most of the patients had 1 to 2 plasma exchanges. However, there were patients who had received 3 to 4 plasma exchanges. And you see also that there are some patients, even though they received 4 plasma exchanges, they had still quite high isoglutenin titers. And in these patients, as in some of those patients, the center decided to do then red blood cell removal from the stem cell inoculum, or there were some patients where they just went on without further procedures. And as they reported, there were no hemolysis reported at the time of transplantation. The second possibility is the immunoabsorption. And there is a non-specific one, which is just a column which filters out immunoglobulins, and there is the specific for AB antibody, which is the glycorex column. And you see that the TheraSorb column on the left filters out all the immunoglobulins, IgG, inclusive subclasses, IgA, IgM, IgE, and also free lambda and kappa. And this product is used mostly outside of stem cell transplantation in immunological disorders. The glycorex column is more specific for A and B antibodies, both IgG and IgM, and the subclasses. Now we, at a certain point, analyzed the efficiency of the glycorex columns, but in kidney transplantation, I show you here, and you see, yes, with the numbers of immunoabsorptions, the antibodies go out, even if you see also a certain rebound in some patients. And it is both for donor-specific IgM and IgG. But what we also saw is that there is also a certain reduction of the compatible anti-AB antibodies, so it is not completely specific. And why do I show you kidney transplantation and stem cell transplantation? Because there, as a matter of fact, there is hardly any information on immunoabsorption pre-transplant in stem cell transplantation. What we have are case series of patients who already have pure red cell aplasia and were treated with immunoabsorption. And that's, as a matter of fact, two case series, both published from the group of Nina Worel, who will talk later on. And you see on the left-hand panel that the black lines were the time where immunoabsorption was performed, and then you see that the isoglutamine titers go down, and as a consequence, the reticulocytes can increase. On the right side, you see the glycosorb column in patients with pure red cell aplasia, and you see that there is also an increase with the immunoabsorption. What we completely are lacking is data with regards to pre-transplant preparation of patients. There are some case reports, but there is no real case series for this situation. But basically, we can say the advantages and disadvantages. The Therasorb is a little bit less specific. Glycosorb is only anti-AB antibodies. Therasorb is off-label. It's not specific, and there is also depletion of other IgG and IgM antibodies. So those patients usually often you require an IVIG substitution. The volume is often a little bit higher that you have to deplete, and it's more often you have to repeat it with Therasorb. Now, the third procedure that you can do is the transfusion of donor-type red blood cells. And that is something which, surprisingly, there are almost better data than for immune absorption and for plasmapheresis. You see here a pediatric population of roughly 50 patients with major ABO incompatible transplantation with a median age of 10 years. And you see on the right the donor reduction in patients with only one transfusion. It is the median titers are not very high prior to transfusion, but they went down. And then there were some patients who had some higher pre-transplant titers, and they required two transfusion of incompatible red blood cells. About the timing, it was given here quite early after the start of the conditioning therapy. Supportive medication. All those patients received high-dose steroids. They received antihistamines, and that was roughly given 30 minutes before the transfusion. The transfusion volume was 1.5 to 2 milliliters per kilogram, and it was given very slowly. In our study, we did it over 12 hours. And most patients, or 60% of the patients, one transfusion was sufficient, and 29% of the patients required two transfusions, usually at the distance of 24 hours. And the goal in this study was to reduce the titer to less or equal to 1 to 4. Now here you see the effects of the transfusion, and this is quite a nice graph where you see that yes, the LDH slightly increases, but it's not very impressive, and also after transplantation, it's not a huge increase. Also, the bilirubin is increasing a little bit, but it's still in a very controlled manner, and there is no renal insufficiency or impairment of the creatinine. And also with regards to survival and event-free survival and overall survival, there was no difference between the two groups. And in total, the side effects were very controllable and very mild. Most of the patients had no or grade 1 or 2 side effects. There were just 3 patients who had grade 3 side effects. 2 had dyspnea requiring oxygen supply, and 1 had hypertension that required medication. There were no grade 4 to 5 side effects. No transfusion had to be stopped due to the side effects, and there were no cases of anaphylactic shock. And there were no relevant clinical signs of hemolysis or kidney damage. This is a pediatric population. There is also some information about adult population here. And that is a study by Sebastian Scholl, and they also did the incompatible transfusion during the conditioning regimen. However, they tried to do it as shortly before transplantation as possible. They had also high-dose steroid and antihistamine. The transfusion volume was between 50 and 150 ml, and the numbers of transfusion was 1 to 2. The goal was, again, to reduce the titer to 1 to 4, more or less. This is a bit a difficult graph to read, but you see basically the number of patients who had a certain titer with anti-A and anti-B, and then you see the reduction, and black is more than 4 titer steps, and this is 1 titer step, and this is in between. So you see that at each level there were patients who had quite good reduction of the isoglutamine titers, but there were also patients who had not such a good reduction. Again, it was very well tolerated. Most of the patients had no reaction, or some patients had mild to moderate reactions, but there were no very severe side effects as anaphylactic shock. So taking together a little bit, this is just a summary slide where you see the 3 different technologies and the advantages and disadvantages. I think the plasma exchange is quite widely available. It brings a rapid reduction of the titer, and it's effective both for IgM and IgG. It is non-selective, and it requires often substitution with plasma, and it may need multiple sessions. The immunoabsorption is highly selective. It preserves albumin and coagulation, has fewer side effects, but it's a costly procedure. It's also limited and requires specific devices and resources. The in vivo absorption is simple, it's low cost, it does not require apheresis, and it can be used also in resource-limited settings. It has the risk of hemolysis, and it requires close monitoring, but I think it is a very feasible therapeutic option. And with that, I'm at the end of my presentation. Just as a summary, I think the outcome of the ABO incompatible transplantation is similar to the ABO compatible. The incidence of post-transplant pure red cell aplasia clearly depends on the level of circulating anti-donor antibodies, and there are different strategies to reduce those antibodies pre-transplant. There is no clear winner, so the decision on what preparation regimens a center chooses is really dependent on the center's preferences. But the transfusion of donor type incompatible red blood cells is feasible and safe for the patient, and could be an interesting option for some centers. With that, I thank you very much for your attention.
Thank you, Georg, for this great talk. As discussed previously, we will take the questions at the end, and it's my pleasure now to hand over to Nina Worel. After preparation of the recipient, we will now look at the second option, the red cell depletion of the bone marrow graft.
Yeah, thank you, Jörg. I'm just fighting now with my screen. Do you see already my presentation, or is it a different?
Yeah, so we see your mailbox and your presentation, but not in the presenter mode.
Okay, let's.
Yeah, now we see you.
Okay, that's good. At least something. Let's try again. When we trained, it worked.
Yeah.
And no, yes.
Yeah, great.
So I will now have the task to discuss red cell depletion from the ABO incompatible bone marrow graft. And just a short reminder is that we deal with different blood groups. So every blood group has different antigens or no on the surface. And in the plasma, we have for the blood group corresponding antibodies, which are directed against the antigens of other blood groups. So What Georg already very nicely pointed out is that approximately half of the allogeneic transplants are performed across the blood group barrier, and from the ABO incompatibility, approximately half are minor incompatible, half major, and 3 to 5% bidirectional incompatible. And this means, of course, that in major setting, which is the main task today, that the donor has red blood cells where the recipient has antibodies directed against these antigens. Whereas in the bidirectional setting, both donor and recipient have incompatible antigens where always the other one has antibodies present in his plasma, which are directed against the other's antigens. And the immunohematologic consequences here are mainly during graft infusion, immediate hemolysis. And when we look at the major incompatible setting, of course, this is especially in bone marrow grafts where a lot of red blood cells are included, which is normally not the case if we use peripheral blood stem cells grafts for transplantation. And this is similar in the bidirectional setting. And during engraftment, which has also been discussed previously, pure red cell aplasia would be a problem in major setting. But what is also a problem is the delayed hemolysis, which comes from residual B cells of the recipient who produce antibodies either against the red blood cells of the donor, or if the donor B cells, which are stimulated with the recipient antigens, massively produce antibodies against recipient blood group, and then we have also fatal hemolysis observed. So what is our preemptive approach in the ABO major setting? When we look for graft manipulation for bone marrow, we try to achieve red blood cell depletion or MNC separation, whereas, as mentioned before, in the peripheral blood stem cell grafts, there is no manipulation necessary. The therapeutic approach has been discussed in the previous presentation already. So in the very first beginning, and this is a publication from the mid-80s, and we all know the lady who wrote this publication. It's Phyllis Workington. She's still working with FACT. Bone marrow was red blood cell depleted by the use of sedimentation aids, and this was 6% hydroxy 2 starch. And when I started in our hospital, we still did this. The bone marrow grafts which were depleted with this approach mainly have been small volume grafts for pediatric transplantation. And how did we do this? So bone marrow after filtration was adjusted to an hematocrit of 25%. So at that time, we used either tissue culture medium or RPMI, but now plasma light A would be a very good solution, as it is approved from the FDA also for infusion in patients and not only for laboratory use. So then after adaptation of the hematocrit, starch is added 1 part to 7 parts of bone marrow, and then gravity sedimentation takes place. So we hang the bag upside down with the line below for 45 to 60 minutes. And due to the rouleau formation of the red blood cells, the buffy coat very nicely sediments on top of the red blood cells. And the red blood cells have then been drained into a secondary bag. And the secondary bag in this study was reprocessed again, adjusted for hematocrit of 25%. Again, he's added, and again, gravity sedimentation with a shorter time as already was in there. And then these RBC depleted bone marrow fractions were pooled, again centrifuged then for 10 minutes, and with a plasma extractor, which is shown on the right side at the bottom, approximately 3/4 of plasma haze volume were removed, and the residual bone marrow cells, the Buffy coat, was resuspended and infused. And this has been done for many years. How was the results in this study? So the median number of nucleated cells infused was 4.4 times 10^8 per kilo, with a range of 1.6 to 7.6. And the recovery, the mean recovery for nucleated cells was 86%. The median recovery for CFU at the time, no CD34 were analyzed, was 98%, and approximately 2 milliliters of red cells remained in the graft. But there are numerous reports with different concentrations of hydroxyethyl starch or even Ficol, which has been used for sedimentation and MNC separation. Another study in 2015 showed what they have done so far, and then focused on the area where hydroxyethyl starch was kind of reduced from the market and is now in a high molecular weight not available anymore. So what they did in the beginning was that they collected bone marrow, and they diluted the bone marrow not to achieve a specific hematocrit, but to achieve a specific concentration of white blood cells, 10 times 10^9. Then divided the volume over 400 milliliter bags and filled this with a maximum of 200 ml, added hydroxyethyl starch, used gravity sedimentation for 60 to 90 minutes, and then with a plasma extractor eliminated the plasma and did centrifugation to volume reduce this. The recovery here was mean with 88%, and the red blood cell depletion again very high with 95%. But in the second part of this manuscript, they asked whether hydroxyethyl starch is still necessary for the sedimentation of bone marrow. So what they did is they manufactured a bone marrow substitute, which was red blood cells, plasma, and Buffy coat. They used 350 ml for 3 portions. In one, hydroxyethyl starch was given, in one Wolovin, and in one nothing. Then they split this bag in 2 smaller bags, and the 140 ml fraction was further processed by gravity sedimentation, and the 185 milliliter bag was further processed by centrifugation, and the centrifuge was set for 250 G for 10 minutes at room temperature with a break. And the results are shown here. In the upper part, you see the comparison of the centrifugation and the gravity manufacturing with the MNC recovery. And what is really interesting is that the gravity sedimentation is much more efficient, but there is no difference whether the product here in black, the bar, contains hydroxyethyl starch, or in the striped Wolovin, or the gray without haze. And in the lower graph, you see the percentage of red blood cell depletion, and there was no difference as well in between the different preparations, but also no difference in centrifugation or gravity. So for that, it could be argued that bone marrow processing without hydroxyethyl starch would also be feasible when you have no other possibility. When we go to the CEPAC system, which is a fully automated bone marrow processing kit, we know that this is a closed kit. It's developed by BioSafe now Sutiva and is also GMP compliant. And there an optical sensor controls the opening of the valves and fractionates the bone marrow based on the cell density. The results are very good also, MNC recovery of 80 to 95%, also very high CD34 recovery of 85 to 98% with a very efficient red blood cell depletion. But 1 hour per unit, one small bag, and if you have a bone marrow containing more than 1,500 milliliters, it's a huge workload. So this device mainly is used for the processing of cord blood and in some centers also for washing out DMSO after thawing peripheral blood stem cells. The advantage of this system is that it is a closed system, as mentioned before, which reduces the risk of additional contamination. It is automated, it has high MNC and CD34 recovery rates, and is very efficient in red blood cell depletion. But the disadvantage is that it has very high costs, not only for the device, but also for the consumables. And sometimes you need 3 or 4 kits for one bone marrow. You need additional training for the staff, and every unit takes you 60 minutes. So this is then 4 hours if you have a large volume bone marrow or even more. When we go then to bone marrow processing with an apheresis device, we have a lot of experience with this, and I think that the majority of transplant centers who are doing allogeneic transplants have an apheresis facility with one of those separators which also can process bone marrow. This is a publication from 2006 with more than 100 bone marrows who have been processed with the older device from Terumo, the Cope Spectra, which was also very easy to manage. And what you can see is that the initial red blood cell content was more than 300 milliliters and was then reduced to 4 milliliters a median with a range of 0 to 11 after the processing. And the CD34 recovery is more than 80% with a CFU-GM recovery of 94%. The only thing is when you just check for leukocytes, you of course see that the leukocyte recovery is low as we lose, and this is what we want, all the granulocytes also. What has been emerged through the last 10 years is the MNC separation program, the bone marrow processing program of the newer device, the Spectra Optia. And this is really a progress, because what you can see here on the right upper side is the bone marrow accessory set, which is a specific bag. You will see this on the next slide a bit better. This bag has spikes with filters. So when you come from the operation theater to receive your bone marrow, you could here filter your bone marrow in this bag. And then you have to add 10% of ACDA as an additional anticoagulation aid. When you go to the device, you enter the bone marrow specific data, which is the volume and the hematocrit. However, it is important to have at least 120 milliliters of packed red cells in the bone marrow, otherwise the automated processing will not work, and you have to add also cross-matched red blood cells from a random donor. What is also important is to use the collection preference tool, which is depicted at the bottom here. And typically for bone marrow processing, you would like to achieve the color number 4, which is the second on the left. And with this, you achieve then a red blood cell reduction of greater than 97%. Of course, also a volume reduction of more than 90%, and the final product volume has less than 200 milliliters. The bag, as I mentioned before, here in the middle, is that you just have the return on the upper part here, and you see that the bag is sealed. This is the blue line here, so that this allows that the already processed bone marrow reinfuses in the bag on the top and will not be directly used again for the inlet. So this is kind of safe to avoid recirculation. And when you have entered the volume and the hematocrit of the product, you will see on the right side here how many cycles the device will need to very efficient collect the mononuclear cells out of the bone marrow graft. During the validation of the device, Terumo did 10 runs with bone marrow, which was also red blood cells containing white blood cells and plasma and platelets. And these products were split, and one part was processed with the COPE spectra, which is the left column, the second left column, and the other one was processed with the SpectraOptia device. And what you see is that the runtime is pretty short compared to the older device, to the COPE, which is approximately 55 milliliters when you have a median volume of 1,500 milliliters. The remaining red blood cells are not significantly different, with approximately 5 milliliters. However, the MNC recovery due to the change also in the shape of the bone marrow processing bag is higher with 99%, and this also reflects a very high CD34 recovery with 97%, which is also not significant to the older device. So when we look at the scheme, which was published already more than 10 years ago in BMT for major ABO incompatible mismatch, when we look for the recipient anti-donor isotiter, and if this titer is 1 to 32 or higher, and you have a bone marrow transplant, then you should red blood cell deplete the component or deplete isohemagglutinins of the recipients by either method which is available, and you should monitor for acute hemolytic reactions. If you have peripheral blood stem cells who contain less than 20 milliliters of red blood cells, which is normally the case, then you can infuse this without modification and just monitor for acute hemolytic reactions, which is normally always done. And in case you have a higher red blood cell content, then you should also consider either to try to volume replete the red blood cells or to prepare the patient accordingly. If the isotiter of the recipient against the donor red blood cells is 1 to 16 or lower, you could infuse your ABO major incompatible graft without modification, and you should monitor for acute hemolytic reaction. So this brings me to my conclusions. So in manually bone marrow processing situations, I have to say, unfortunately, that the use of sedimentation aids like hydroxyethyl starch is mainly not available in most of the countries. And there are other approaches which have been published where gravity sedimentation without haze leads also to very good and efficient red blood cell depletion and MNC recovery. In automatically systems, I would say that CPAX is efficient, but has its cost and time extensive. You need multiple procedures, especially in high volume bone marrow grafts, which is sometimes from every side not affordable. And I have to say that apheresis devices are easy to use, they are safe, They are very efficient in red blood cell depletion, but also in MNC recovery and CD34 recovery. They are not that cost extensive, and very often the staff is already trained due to the numerous peripheral blood stem cell harvests which are performed. And with this, I want to thank you for the attention and happy to take some questions at the end.
Thank you, Nina, for this careful and extensive overview. And with that, we continue with the talk from Laura Infanti on transfusion policy in ABO incompatible bone marrow transplantation.
Thank you very much, Jörg. I hope you can see my screen.
Yes, we can see it, not yet in the presenter mode, but we see the slides.
Coming. Just a moment. Is this okay now?
That's great, yeah.
Okay, thank you. So I will, in the next minutes, summarize the main principle of transfusion policy in ABO incompatible bone marrow transplantation. We have already heard a lot about what it means when antigens and antibodies of a donor and the recipient encountered. And first of all, I want to say that the EBMT handbook in chapter 24 gives the essential recommendation for the transfusion in overall in allogeneic stem cell transplantation, but also with specific recommendations on ABO incompatible mismatches. And because probably many of the listeners are not very familiar with transfusion medicine specific issues, I just want to briefly mention some basics, and I will focus in my presentation on the practical management of patients. All transfusion medicine, especially immunohematology, is based on the interplay between antigens and antibodies. In this case, for the topic of today, the antigens are the AB antigens and the antibodies are the AB isoproteins, as we have already heard. Another important thing to consider in the course of transplantation, there are many reasons why hemolysis or anemia can persist in a recipient. Pure cell aplasia has already been addressed by Professor Stu. There are other complications such as pathogenic lymphocyte syndrome, many other autoimmune or alloimmune phenomena, and of course, these patients need all the way long transfusions. Without dwelling too much on blood products, I just want to remind that depending on the part of the world where you're working, maybe the specifications of the blood products that you transfuse may be slightly different. We are going to the not recommendations, to the prescriptions and regulations of the ADQM. But of course, in other countries, the AAPD regulations, FDA regulations are used. So there may be some differences in the specifications of blood products, but regardless of these differences, it is recommended that all stem cell recipients, and of course also the compatible mismatches, receive leukocyte-reduced red blood cells and irradiated. On the other hand, there is no real robust evidence on the advantages of CMV negative or fresh RBCs to be transfused. So what we do in Switzerland, for example, we do transfuse CMV red blood cells regardless of CMV status of the donor and regardless of the age of the product. The same goes for platelets, different manufacturing processes, different ways to store platelets, and different specifications, but again, also recommended by the EBMT, leukocyte reduction is essential, irradiation, or alternatively, pathogen reduction in the centers where pathogen reduction is implemented. In this case, platelets do not need irradiation. Then we come to our patients. They come to the transplantation ward, and at admission, we need precise information about the recipient and also about the donor. For both, we need a complete AB0 blood group. That means a clear determination of the antigens and the isobutylins. We measure always IgG and IgM. Maybe also different in other parts of the world according to the resources, according to the local processes. We also need the titer of the isobutylins in both the recipient and the donor. We also need the determination of the rhesus phenotype, including KEL, which is not a rhesus antigen, but is usually determined at the same step for both. And in Basel, for example, or in many other centers, we also have a determination of RBC extended phenotype, including several other antigens. This may not be the case everywhere and maybe not be strictly necessary. Then, when we transfuse our patients, we follow generally quite restrictive thresholds. This is not the topic of the talk, but I just wanted to remind that in stable, hemodynamically stable patient, a threshold of 70 grams per liter hemoglobin can be followed as a trigger for red blood cell transfusions. And in any case, red blood transfusions must be given compatible or identically to the AB0 group of the recipient. We are talking of the time before transplantation, of course, and whenever possible, as also recommended by the WBMT, also D, the antigen D and C and E antigens should be compatible with both the donor and the recipient. For platelets, we also have our thresholds that may be very similar to many other centers, but maybe also a little bit variable and depend also on the clinical situations. And again, whenever possible, and those who work in a transfusion laboratory know that it's not always the case, also platelet products should be given for the same blood group, AB0 blood group, or compatible for the recipient. And also, it is important to consider RHD negative platelets components for RHD negative recipients. Plasma has to be selected according to AB0 compatibility with the recipient, of course, and the indications are given by the clinic. The day of the transplantation, there is a change in the transfusion policy. This must be very clear, defined. And in chapter 24 that I mentioned already, you can find a very detailed table with the recommended choice of the blood group for all three blood components that we already described, and for the major, for the minor, and for the bidirectional mismatches. And I will not go in detail on this table, and it is quite easy to understand if you keep in mind that the general rule is to give blood products which are compatible with both the donor and the recipient. And just a word for those who are not familiar with the management of blood products inventory, it is not good practice to give in every case, in each case, red blood cells of the blood group O or O negative and plasma of the blood group AB. These are very precious resources that have to be saved. And so there are cases where it is necessary to do so, but there are other cases also in a AB0 mismatched transplantation where red blood cells, for example, of A or B blood group can be safely given. Then from the day O, up to engraftment or up to 6 months after transplantation. This also varies among institutions. The definition of the transfusion strategy must be clearly communicated to all the important partners who take care of the patient. The nursing team responsible for the transfusions, the hematologist, but also the other centers who referred the patient in the first place for transplantation. What we do, and I think is done in the majority of the centers, of course, we define a transfusion strategy electronically in the recipient's file, and we give on the day of transplantation a provisional blood group card indicating the date of transplantation, the AB0 blood group of both donor and the recipient, and the choice of red blood cells and plasma that will be taken from this time. And this is an example in German, but all the important information are given. After transplantation, it is important in AB0 mismatch to monitor isoglutinin, to monitor also possible laboratory signs of hemolysis, for example, determining the direct antiglobulin test. We do it 3 times a week. And if the test is positive, we perform an antibody screening and antibody identification after elution, using also the corresponding panel with A or B test cells according to the kind of mismatch. Then we already heard how isoagglutinin can be reduced in pre-transplantation setting. After the transplantation, we expect that red blood cell engraftment and the switch to the donor blood group would occur about 2 to 3, 4 weeks after the transplantation. This can be variable, of course, and it is important to monitor the reticulocyte count to demonstrate that a new erythropoiesis has taken place in the recipient. And this, of course, in cases where no other clinical complications occur and the erythropoiesis can develop, let's say, normally after transplantation. The AB isoagglutinin are expected to go down with the time, but this is also very variable, and they will eventually disappear in most cases, but there is no really clear definition of the timeline for this. And what all studies show is that A isoagglutinins tend to persist longer compared to B isoagglutinin, for example, in this study published 3 years ago. And also these authors identified that the background disease, in this case myeloid diseases, are also associated with a longer persistence of isoagglutinin in the post-transplant period. Pure cell aplasia was already discussed. I will not dwell on that. I can only say that from a transfusion medicine point of view, this means that the patient must receive transfusions much longer, and complications from this immunologic complication can occur for especially iron overload, but overall also pure cell aplasia does not appear to have a significant impact on other clinical outcomes. Passenger lymphocyte syndrome was very briefly mentioned by Professor Worel. I think it is an acute onset hemolysis due to AB isoagglutinin produced by the lymphocytes present in the graft, and usually appears on 2 weeks after transplantation. But of course, also in this case, other causes for acute hemolysis must be ruled out. This condition is very difficult to recognize because in most cases it is very mild and it can be seen only with an elevation of hemolysis parameters in the laboratory, but also severe and lethal cases have been described in a reduced intense conditioning and bone marrow graft, specifically risk factors for the occurrence of passenger lymphocyte syndrome. And finally, after discharge, when the patient had a good complication without complications, post-transplantation outcome, if no transfusion are needed, the provisional blood part that we gave on day 0 remains valid for the following months. In our center, we consider this the validity until 6 months after transplantation. During this time, we do not need to monitor AB isoglutinin and or other immunohematologic parameters. After 6 months, when the AB0 antigens and isoglutenin antigens of the recipient are clearly of donor type, maybe also the other red blood cell antigens if they are determined, for example, the rhesus phenotype, and if the anti-donor or anti-recipient isoglutenins are disappeared, then we can switch to the definitive blood group, giving the patient a so-called definitive blood group card. This is an example. And if transfusions are still needed for whatever reason, then the provisional transfusion policy is still valid for the patient until a resolution of the condition. So this was just an overview of practical implications for the transfusion support of our patients with AB0 incompatible transplantation. And thank you very much for the attention.
Thank you, Laura, for this great talk. We have one question left in the Q&A. In the case of transfusion of phenotyped red blood cells for prophylaxis, so in the absence of antibodies, when there is a mismatch between the donor and the recipient, which phenotype should be respected, that of the donor or that of the recipient?
Does anyone want to answer? So I do it. So this is a great question that we do not have an answer to that. Because in many cases, you can choose your red blood cell concentrates which are compatible with both rhesus phenotypes. But in many cases, it is not possible. Usually, after transplantation, we switch to the donor phenotype. We did not observe high elevated risks for allogenization against GC03 antigens, but this may occur, of course. There is no real recommendation about this problem. And this is also the question that our laboratory clinicians always ask us, and we always say we don't really know. But we switch usually to the donor.
Okay, so thanks a lot. There's another question that might goes to Nina. If the initial disease relapses, as can be confirmed by chimerism results or other tests, are there also again recipient red blood cells in the blood? You're muted.
Sorry. This, of course, depends on the chimerism, which is normally also tested when a patient experiences a relapse. And what we would then go back in our routine is to compatible red cells, as you do not know whether you have a chimerism where already still donor red cells are in the peripheral, in the circulation, and also isotiter from the original blood group emerge. So we would then treat like in the transplant setting and try to achieve a remission and then try to, change the blood group again.
Okay, so thanks a lot. It seems you have been very clear, everybody, so there are no further questions. So I hand over to Nino for the closing remarks.
Yeah, thank you, Jörg. Yes, first I want to thank WBMT for organizing this and for hosting us. And all those, I think we had approximately 80 patients in the auditorium. It was from my side, I have to say I learned a lot. Depending on where you are situated globally, you will maybe have not access to all the possibilities we explained, and this is for sure the immune adsorption or also very expensive bone marrow manipulation steps. But with what Georg pointed out for the pediatric cohort, and I think this is the cohort which normally receives bone marrow in also emerging countries, we would go a very good way. It is safe, as we have learned. And also, if you could, if you have apheresis devices you could use, then I think this would be also a very easy procedure for bone marrow manipulation. So as always, use these things that you are used to, and you can handle. And if there are any further questions, you could contact any one of us to address your needs. Thank you.